So our whole purpose of this is to make you mentally prepared for something which is going to be unexpected. Okay, so you will be just sitting on a station and two scenarios are going to come back by like one by one, and you will just know, okay, you are on this station, and then the 20
Right.
minutes may be very quickly. So we have
Okay.
it that way only. So when we are in our classes, we already know, okay, today we are going to discuss andrology, so we are prepared for the Viva more thoroughly, and probably we are able to
Yeah.
answer better. Now, since we have completed 50% of our course, now what we are planning is to frequently take up the mock sessions, so that among those 4 stations that we have done, we'll pick up any one station randomly and discuss it. Okay,
Sure.
we'll start the timer. So today you are on the pediatric station. Okay.
Okay.
Okay. So you have a 3-year child. Sorry, just a sorry. So you have a 3-year child. He was brought to you by his mother, and with an absence of testis in the right scrotum. How do you want to evaluate?
Okay, so I would want to see this child in a dedicated pediatric urology clinic with the parents and in the presence of a pediatric nurse as well. I want to take a full history and examination from the child. I'll start with the history. In the history, I would want to know if the testis was ever in the scrotum before. I would want to know how long has it been since they noticed it. If it is that the child was born prematurely, was the birth rate? Take a look at the antenatal records. I'd also want to ask about a family history of undescended testicles. If it is that there was an issue with the testicle not being present before, was it fixed? Was any inguinal surgery done?
Okay.
If the patient has any medical conditions, etc. In examination,
Okay.
once I have
Okay. So you took the history from the mother, and you got that the child is having absence of testis since birth. Okay.
mhm.
So with this history, do you want to take any other history apart from this?
Okay, so if there's the child had abscess of testes since birth, I would want to know if any intervention was done, like a laparoscopy before to determine if it was an
Okay.
undescended testicle.
Okay. Okay. So proceed.
Okay, so well, I've completed the history. What I would want to do is to go ahead and examine the patient. What I would look for specifically, I would look at the weight, the height, and the body measurement parameters of the child, general health status, and then I would examine the abdomen, making sure that there's no abnormalities. The musculature of the abdominal wall is fine. Looking at the cranium, looking at the penis, looking for any associated hypospadias.
Okay.
Specifically at the testicle, I would want to know if it is that the sac is appearing hypoplastic or not, and if there's contralateral hypertrophy of the opposite testicle.
Okay.
I'd examine the inguinal region. Ideally, all of this will be done with warm hands in a warm room with a chaperone and verbal consent given as well. I examine the back just for completion to make sure there's no abnormalities of the spine.
Okay. So you went on to examine, and you found that the testis is present on the right groin. Okay. So it's in the inguinal canal. And what is your next plan? There is the opposite testis is normal. How do you want to proceed?
Okay, so what I will do is firstly, I would counsel the mother on the findings. I would tell her that there appears to be the testicle in the right groin. I would attempt to see if it is, I would lubricate my hands to see if I could bring down the testicle into the scrotum without any pain. If it is that the child is having pain or discomfort, I would cease doing that. And then I would counsel the mother now that we have a testicle in the inguinal region, which is an ectopic site for the testicle, and we will need to intervene to fix it, to bring it down, because there are risks associated with the testicle being in that region.
Okay, so you mentioned that if you will try to manipulate the testis into the scrotum. So if it is successfully possible, what is your concern in that case?
So my concern in that case is that this may be ascendant testicle. So you might have had an incident where the testicle was in the scrotum, or it was retractile, and now it has become fully ascended into the inguinal region, or it may be a truly undescended testicle
Okay.
from birth, but I have no way of telling that.
Okay, can you tell me what is the natural history of a retractile testis?
I think can't remember the figures, but I know that retractile testis, um, basically it's in the scrotum, and because of an exaggerated cremasteric
Okay.
reflex, it
Okay.
goes up.
Okay, so as I said, the child is having testis in the at the level of the superficial ring, and you try to bring it down. It's not coming. So it's a diagnosis of an undescended testis. You have counseled the mother about the nature of the disease. So what's your plan of management?
So the plan of management would be to perform a inguinal orchidopexy for this patient. I would want to consent the parents using the Bowes, if there's a, I don't think there's a Bowes information leaflet for kids, but if there is, I would use one. I would also, well, I would quote her on figures of the complications. So I would want to tell her, one, it's important that we do the surgery because there's a higher risk of malignancy. And there's also associated risk for fertility. It can impact future fertility of the child. So we want to bring it down into the scrotum, into the normal position. And I would also tell her that's why we need to do it, but there are complications associated with the procedure as well. So with the procedure, she needs to be aware that there might be most commonly, there might be a 10% risk, I believe, of testicular atrophy. There's also bleeding, infection risk, damage to structures as we bring it down, anesthetic complications. So once she understands all the risks and the benefits, then we would proceed.
Okay, so you explained about the complications very well. What about the, so you mentioned about the fertility and the malignancy issues. So at 3 years, you're planning to do a orchidopexy. How specifically will you counsel regarding the fertility rates?
I would tell the mother that um, the paternity rate is, I believe, 90% comparable to somebody who has normal testicles,
Okay.
but there is a decrease in the sperm count. But I'm not too sure. I can't remember the exact figures.
Okay. So you counsel the mother about so many complications and about the, since it's already 3 years, what is the ideal age for operating this?
According to the Baus and Bapu consensus, I believe the ideal time is between 6 to 12 months, but 6 to 18 months, but ideally it's done before 1 year of age.
Okay, so it's already late. You counsel the mother about the possibility of decreased fertility and increased malignancy. So the mother is asking whether any options for medical treatment is available.
There have been incidences and data showing the use of nasal GnRH, but usually there's no improvement in descent after the period of 3 years, I believe. Yeah, I don't think spontaneous descent occurs after 3 years. So the chances of this coming down are low, and there's no data to support the GnRH, no
So,
definitive data, sorry.
so current recommendation for the medical treatment, if any?
Uh, I don't believe there's any guidelines supporting that.
Okay. Okay, so the mother is convinced for the surgical exploration, as you said. So how do you proceed for that?
I would want to perform this procedure in the operating theater after I've obtained informed consent, after the completion of the WHO checklist with the patient cleaned and draped in a supine position. I would make an inguinal incision, open it down into layers to expose the inguinal canal and the superficial and deeper rings. I would identify the ectopic testicle and free it from all attachments, ligate um, the transversus vaginalis, and free the gubernaculum, and then bring it down into the testicle and fix it in that subdartus bulge.
So you attempt to do that, there is resistance and you're not able to gain adequate length. How can you gain the adequate length?
We can perform the Prentice maneuver, which is division of the inferior epigastric artery, so that we can make a direct line into the scrotum. This is
Extra many
uh,
things you can do prior to Prentice maneuver.
um, not that I'm aware of.
So anything else? So straight if you're not able to gain the length. Yeah. Okay, so
So
you
if I'm not, we could stage the procedure as well. We could do a stage
okay, we are coming.
procedure.
We are coming to that. So
Okay.
you plan for the Pentis maneuver. Can you please tell the maneuver? What is it? What is actually the Pentis maneuver?
I believe it's division of the inferior epigastric, and what it does, it allows you to take the testicle from the intra-abdominal route directly into the scrotum,
Okay.
or direct. I think it's, yeah, it's creation of like a direct route.
Okay.
So
Okay. Okay. So you do the Pentis till you are not able to reach. What can you do else? So you said about the stage procedure.
right.
So in this case, suppose you have not taken consent for the stage procedure. You have taken consent. What do you mean by a stage procedure? Like, what do you want to do?
So in the stage procedure, we ligate the testicular artery and we allow for collateral circulation to develop between other arteries, like from the vas, the vasal arteries, etc.
So
And then
so you mean it will be an intra-abdominal approach?
I would want to say yes.
Yeah. So my question is, suppose you have not taken consent for the stage procedure in this case, what will be your approach? You're not able to bring the testis down. It's a stage. Can you proceed for the stage procedure, or what will you do?
If I have not taken consent for the procedure, then I
Okay.
cannot proceed.
So what will you do in that case?
So in that case, unfortunately, I will have to um, close the patient, uh, bring the testicle as low down as I could, close the patient, and then
Great.
counsel the procedure. I believe in a case like this, you should follow duty of candor as well, that you need to fully disclose what has happened to the parents as
Right.
well.
Okay. Great. So you have done it. When do you plan to? So you suppose you do this and you are able to bring the testis till the root of the scrotum. So for the next, how do you, when do you plan for the next surgery?
Um, that's I got it down into the testicle, you said?
So
Into the scrotum, sorry.
you are not able to bring it to the fundus of the scrotum.
Okay,
It's still
okay. So I perform the stage procedure. What I will do is come back in 6 months and then see if it is I could bring it down into the scrotum.
okay. So you do the stage procedure as well after 6 months. Now the testis is into the scrotum. Well, what about the atrophy rates? Like how common it is to become the testis to become atrophied?
So with um, inguinal oculopexy, I think it's a 10% rate. But if it is you have a stage procedure, I believe it's about 30.
Okay. Okay. So the patient comes to you, okay, after a couple of years, and the mother has got the child, and now the child is having an atrophied testis. What is your next plan?
So I would once again, if it is the patient represents, I would counsel the parents that, okay, it's unfortunate that this has happened because obviously they might be a little concerned or aggravated. So I'll try to alleviate any concerns that they have at that point and then tell them if the testicle is atrophic, um, then there's also associated malignancy rate with an undescended testicle. The best bet might be to take it out.
But it's not undescended. It's now in the scrotum.
So, but it still has an increased chance of
Okay.
being malignant. So
Okay.
I would counsel them on orchidectomy.
So do you want to counsel for anything else along with orchidectomy?
And well, hopefully I did the contralateral orchidopexy at the time of
Okay. So we'll
the
stop here. We'll discuss it after we do the next case. Okay. So we'll
sure,
start with the
sure.
next scenario. So sorry. Okay, so you have a 1 year child. He has been got into the emergency with the febrile UTI. Okay, so what's your plan to approach?
Okay, so I would want to see this child myself because child is young with a febrile UTI. I would want to make sure that I take a full history and exam from this child with the parents present. And what I would want to know is if it is that this is the first time the child has presented with a UTI, if any treatment was given, for example, antibiotics, and how long they were given, because I would want to know if it is the child was given antibiotics and not responding after a 48-hour period. Was there a history of any febrile UTIs in the past, recurrent UTIs? I'd also want to find out about the antenatal history as well. If possible, review the antenatal notes, looking for things like antenatal hydronephrosis, if there was any incidence of that, what was done, and what investigations were done. I want to take a history from the parents in terms of the siblings, if there's any siblings with similar conditions, if it is that the child has any medical diseases, immunocompromised states, up to date with vaccines, nutritional status, etc. I would examine the child in the presence of a chaperone and with verbal consent from the parents. I would want to examine the child in terms of palpate the belly, see if there's any palpable bladder, examine the genitalia. For example, is it a male child or a female child, may I ask?
Male child.
Male child? Okay. So examine the penis for any hypospadias, if the child is uncircumcised or not, examine the scrotum, examine the back for any spina bifida, and check for any renal angle tenderness, and then proceed.
Great. So you examined, you took a history, you found that the child is dehydrated and is having febrile UTI episodes for last 2 to 3 days. Okay, and it's a high-grade fever that the child is running. How do you resuscitate the child?
Okay, so I would want to, one, get baseline vitals and the weight of the child, and then give a bolus of 10 milligrams, 10 mils per kilogram infusion of normal saline for the child, repeat the vitals, and then once I would check things like capillary refill peripherally to see if it is that I have good capillary refill, and the vitals to see if they're improving with the bolus, and then proceed, because sometimes they might need repeated boluses.
Okay, so you resuscitated the child is now stable hemodynamically. What kind of UTI do you think the child is having?
Well, this more than likely might be a complicated UTI,
Okay,
or recurrent UTI due to some abnormality
so the child does not have
in the
previous
urinary.
the child does not have any previous history of UTI. It's a complicated UTI, as you said. So what do you mean by an atypical UTI in a child?
So atypical UTIs that present with the child grossly unwell. If it is that they have a non-E. coli organism, recurrent bouts of cystitis, I believe it's tree cystitis.
Oh, so uh, are you there?
You hear me, Dr. Ankit?
Yeah, I can hear you now.
Okay, I think I lost you there for a second. Where did you lose me at?
So could you please define a typical UTI?
Right. So, yeah, not responding to antibiotics over a 48-hour period. Those are some features of atypical UTI.
Okay, see, this child has a typical UTI. Okay, what's your next plan of management? So you have
So first,
antibiotics, the child's fever is now better, he's now afebrile. You fit the criteria for the atypical UTI. Now what's your next plan?
so what I will do is follow NICE guidelines. They have a protocol for children with atypical UTIs. So what I will do is get an urgent ultrasound, or immediately if I can get one in the department, and review that. And based on the ultrasound findings, then I may need to order some more investigations as well.
Okay, so is there any other investigation which is recommended in a febrile UTI apart from an immediate?
Yes, you will do a VCUG as well.
Okay, okay. So you got an ultrasound. So this is your ultrasound finding. What can you appreciate?
Okay, so I'm seeing ultrasound images given I'm not seeing labels in terms of if it's right or left kidney, but
The left
there
is
is
hand side is the left and the right hand side is the right kidney.
right hand side is the right kidney. Okay, so on the right kidney, I'm seeing a dilated pelvic ileal system, and on the left side, I'm seeing what appears to be a prominent pelvis. So this child looks like they have moderate hydronephrosis on the right side and mild on the left.
Okay, so what do you want next with this ultrasound?
So my concern with a male child at 1 year of age with bilateral hydronephrosis is possibly a missed posterior urethral valve. So ideally, I would want a mid-urethral and cystourethrogram to confirm this. Or ideally, I could look at images in the bladder from the ultrasound as well, just to have an idea if there's any distension or thickened bladder wall as well.
So the bladder images in the ultrasound are normal.
Okay, I still want to get a VCUG then.
Okay, so you got a VCUG. This is your VCUG imaging.
Okay, so looking at the VCUG on the right side, there's gross dilation of the ureter and the right kidney. And the left side, I'm seeing dilation of the ureter and the renal pelvis with dilation of the major calyces.
Okay,
So this
so
has some sort of obstruction going on.
yeah, so the urethra is normal. The posterior urethra is not dilated. Okay, so what's your diagnosis based on VCUG?
I think I lost you for a second there.
Sorry for the interruption.
Sorry, I lost you for a second there. I think I've taken off my video so I don't lose the bandwidth. Yeah.
What's your impression from the
What was
VCUG?
the question? Sorry.
What's your impression from this VCUG?
So So my impression is that the child has some obstructive process. So I'm not seeing the posterior urethra or a dilated posterior urethra or hypertrophied bladder neck. So this, if it is ideally, I could rule that out by looking at the images. This child could either be a missed posterior urethral valve or bilateral vesicular ureteric reflux.
Okay, so the posterior urethra is normal.
Okay, great. So I think this child possibly has bilateral vesicular ureteric reflux.
Okay, could you grade the reflex as well? Here in this patient.
Right. Because major and minus. So this would be grade 5 on the right, and I would give it a grade 3 on the left.
Okay, great. So you discussed with the radiologist and you got a grade 4 on the right and the grade 3 on the left. What's your next plan now?
Okay, so given the fact that this child has bilateral reflux, I ideally would like to get a DMSA scan because I would want to look for any cortical scarring because although the child has only had one episode that presented before, I would still want to rule out any cortical scarring.
Okay, so what is the best time to get a DMSA scan after the fibrillary UTI episode?
3 months,
Okay,
I
so
believe.
you got a DMSA scan and this is your DMSA. What's your impression from the things?
So there appears to be an area of photopenia on the right superior pole. The left kidney looks normal, so I would say that definitely we have scarring on the right kidney superior pole.
Okay, great. So what's your next plan? You got this DMSA and the DMSA doesn't show significant decline in the renal function. Okay, there's a and with the bilateral reflux, what's your next plan?
So what I would want to do is first take this information and counsel the parents. I'd want to let them know that there's an area of photopenia on the right side of the kidney, which may indicate that the previous infection has damaged the kidney. However, based on the information that we have, boys usually have more severe grades of reflux, but they tend to resolve. They're more likely to resolve, but also noting that the higher grades of reflux, the resolution rate is also lower. the first thing that I would want to do is counsel the parents on need for empirical antibiotics, just to prevent any breakthrough UTIs, as well as to treat with any bladder bowel dysfunction, ensure adequate hydration of the child to prevent any UTIs. I would quote the River trial in terms of prophylactic antibiotics for the child, noting that it has decreased the incidence of febrile UTIs in children put on prophylactic antibiotics, but not the rate of renal scarring. That's why we use it. So I would try these measures first. Also, because I've mentioned the fact that higher grades of reflux require surgery, I would also mention that we can use surgical intervention if it is that they want to proceed and they're worried or they're concerned versus doing something conservative.
Okay, so
So I'll
you
give them the options.
Okay, so you counsel the parents regarding the conservative treatment. As you said, you will start on antibiotics as per the evidence that you quoted, and regarding the conservative measures like the bowel draining and the bladder training. Okay, so what are the red flag signs that you will explain the parents that that you will consider for surgery?
So I would counsel the parents that should there be decline in renal function, should there be breakthrough infections, although they're on prophylactic antibiotics, if it is the patient becomes extremely symptomatic with pain, those are the things that I will consider as red flags, and they would report that to me, and then we can discuss proceeding to surgery.
Okay, so who are the patients likely to be proceeding towards surgery, like requiring surgery and who are likely to fail medical treatment?
Those are patients with higher grades of reflux.
Anything
They're the
else?
ones that not that I could recall.
Okay, no problem. So, what about the patient comes back, the child is back to you after a year, and this time he again has a breakthrough UTI in spite of prophylactic antibiotic. The parents are concerned and they want to proceed for surgery, as you have explained already to them. What surgical option do you want to proceed for?
So I would want to counsel them for a subtrigonal injection of I think it's I'm forgetting the name of the gel that we use.
Okay, no problem.
Deflux.
Okay. Okay, so
Yeah.
you proceed for the injection of the deflux, and
Mhm.
okay, so can you tell me what will be the outcome of that injection therapy?
I can't recall the exact outcomes, but I think I want to say 80%. There's an 80% success rate with deflux injection.
Okay, great. I'm going to name the technique for injection.
It's you do it under cystoscopy guidance. There's a kit, and you basically do a sub-ureteric injection
Okay.
of deflux. I think
Okay.
there's like 3 sites you can do it. Depends on surgical practice. Some do inferior to the ureteric orifice opening. Some do inside the ureter itself, and I believe there's one more that I can't recall.
Okay, great. So you also explained the parents that about the outcome, which you said is around 80%. Suppose the child does not succeed to the uh, endoscopic injection. What alternative do you have?
Well, in this child, because I have bilateral vesicular ureteric reflux, the surgical option that I would employ is the Cohen's cross-trigonal reimplantation technique, because both ureters are involved. I'll counsel them for that.
Okay. Okay, great. So we'll stop here. It's already time. And weekly we will discuss a few points. I think, what do you think was your performance?
Honestly, having the spot dropped on me and pediatrics, we don't practice pediatrics much, so it's like basically me trying to read and recall everything. So my heart is pounding, but I
Okay.
honestly, there were some mistakes. I think I need to recap some data But I would give myself a fair.
Not a fail, definitely. Fail is something that you don't progress at all. You don't progress till the management, and you are just. So I'll tell you what's actually the fail is. We'll discuss one by one, and we'll give
Okay.
a tentative score for your performance. It could be definitely better from what you did, but there are certain things that, as you said, you are not practicing pediatrics, therefore you need to revise more. And
Hmm.
one of the tough situations, tough station that one encounters in the first half of this exam. Okay, 20 minutes is too much because you don't get a break between two different. So like if you are on onco, you will get a break, like you kind of thing. Like you have an RCC and then suddenly you will have a bladder. So you have a totally different topic of discussion for 10 minutes. In pediatrics, it's just
Right.
very monotonous. Sometimes antenatal hydronephrosis itself is 10 minutes, and then another situation, PUV, that again goes for 10 minutes. So let us take up this
Right.
in the test is okay. So it's one of the most common scenario that you are going to get from pediatrics. That's why I kept it here. And history, you have said most of the points. When the examiner is asking you, is there any other history you want? So there is definitely something that you are missing. Okay, usually the examiners don't stop you at history, but if you are missing something, then the examiner might stop you. And the reason why I stopped you because I wanted to know for any syndromic association. Okay,
Ah, yes. Okay.
at this point to your notes. So just add down the points which you are forgetting. Definitely, I'll have the recording for you. So
Hmm.
the thing is, apart from this, you covered all the points, the antenatal history and everything. The risk factors you mentioned, prematurity, I think, and so low birth weight and everything you mentioned. Another thing is in examination. Uh, so once you started talking about the examination, then in the middle of the examination, I think you recognized that you forgot about chaperone and warm hands and everything, and
Yeah.
then you went, okay, it's
Yeah.
you can do that. It's no problem that you do. But if you keep practicing and keep giving mock exams, you will understand that you start with that only, and it will become a reflex.
Correct.
Another thing is when you talk about examination, the first thing, try to look at the normal side first. Okay, so
Okay.
especially when you have a testicular tumor or an undescended testis kind of scenario, please try to do that way. Another thing is you have to mention first, you will try to find out whether the testis is palpable or non-palpable. That should be your first priority. Then you try to
Okay.
categorize. If the testis is palpable, you will try to bring it down gently towards the scrotum and see if it is a retractile testis or it's actually an undescended testis. If there is a resistance, you will stop. You will make sure there is no pain. And if there is a non-palpable testis, the whole thing doesn't come. You mainly try to rule out an ectopic testis. Okay, in the ectopic
Mhm.
sites, like in the perineum, the suprapubic region, you try to rule out the ectopic sites. Okay, in a palpable testis, your differential is a retractile. Okay. In a non-palpable testis, your differential is an ectopic. As you said, you will try to look for hypospadia. That's a great thing. That's a good point to mention. Also, another H, hydroceal, this hernia. Okay. There might be an
Okay.
association with sac. So great. You covered all the points in examination very quickly. You spent, I think 30 seconds more. You can decrease the time there. Quickly, we will come to the counseling part. Then you were asked to counsel the mothers. Then you will have to start by talking about, as I always say, nature of the disease. And when you talk about the nature of the disease, you have to say the ideal age of treatment for this disease was actually 6 months to 12 months. 6 to 12 months was the ideal age of treatment. Since the child is already delayed, the reason why the examiner has given you a 3-year age is there has to be some difference in your counseling than a uh, normal infant counseling. Okay, so now that you have to make sure the mother is explained about this delayed presentation and the delayed and the complications and the concerns with the undescended testis when it is managed after 1 year. So you have to explain about the poor fertility rates because you did not explain. You said about the 90% will be the paternity rate. That's only when you're doing less than 1 year. Okay, so unilateral undescended test is, so I'm not going to too much of percentages now. We already have discussed in the class. It's just to highlight what you could have extra points that you could have added. Okay, you can go through the class lecture again. The thing is, 3 year, you have to be careful that certain extra points have to be explained to the mother regarding, okay, this is delayed presentation, and that has to be emphasized to the examiner also that the fertility rates will be less than 90% for a unilateral testis. The rates of malignancy will definitely be increased fourfold. Okay. And Also, you explained about you will counsel the mother that the child will require treatment because the fertility will further decrease and will malignancy rates will keep increasing till puberty. And also there will be increased risk of torsion and there will be hernia associated and can be other complications like the testicular atrophy might be there. So these are the different things you will counsel the mother. First, number you will, if you operate, if you have to explain about the complications, you explained about the complications, but the problem with was the rate of the complication, the rate of the atrophy that you mentioned. You need to quickly revise it from the class notes that the atrophy rates for an inguinal is just 2%. Okay, it's not 10%. It's too much. 10% is too much. For a two-stage Fowler Stephen, it is even less than 10%, 8%. Only in a one-stage Fowler Stephen, which is not done nowadays, it is 28%. So don't worry about it. The
Oh,
atrophy rate
wow.
is 10%. Okay, so
Yeah.
it's there in the class notes. You can revise it there. And these are
Sure.
something to explain in the complications and the consent for the mother. Then the mother is as soon as you said the atrophy rate is 20%, definitely the examiner will be alarmed by that, and the examiner might give you a situation where the mother is not willing for surgery now. The mother says, okay, I will not proceed for surgery, keeping in mind such a high trophy rates. Let me take through the medical treatment. The Viva can enter into the medical treatment. And as I said, if there is a question on the medical treatment, the best answer is it's currently not recommended for a unilateral undescended testis. But even if the mother is insisting, I can say there is some evidence in the literature that if you offer in the 6 months to 12 months in that age group, there can be some evidence in improving the descent of the testis with the GnRH analogs. Okay, but again, this is not an ideal age for the medical treatment as well. However, if it is at all to be recommended that the examiner is asking, it is for a bilateral undescended testis. Okay, so that's the only
Okay.
indication for a medical treatment, if at all has to be given. But standard treatment is not that. Standard treatment is surgery. So
Okay.
then you proceeded for surgery and you said there could be some Bowes leaflet and all. Don't go into that confusion. Okay, just said I will hand over the Bowes information leaflet for orchidopexy. Doesn't matter. Okay, the examiner might not be aware of that. But if you say I'm not aware that there is existing of Bowes or not, so it's better to keep the words limited. And then you were asked about the steps of surgery. You mentioned about some exploration of the inguinal canal. And first is you identify the gubernaculum, identify the testis, divide the gubernaculum. Okay, and then you proceed to try to gain length. And when you are not able to gain length, Prentice is not the first thing that you do. The first thing that you do is you try to divide the cremaster muscles and the the basically the adhesions. You try to remove the cremasters, go at the level of the deep ring, try to dissect around the fat at the deep ring, and then if you're not still able to gain length, then you try to do a Prentice maneuver. And it's better that you say Prentice maneuver is basically medialization of the spermatic cord. You can achieve that medialization without even dividing the inferior epigastric artery, but just putting the testis inside and taking out medially through the inferior epigastric. Dividing is an old technique. You can still say, but it's better that you say the definition is medialization of the spermatic cord to gain extra length to bring the testis. When you are taking consent, make sure you explain the mother that it might not be possible to get the testis into the fundus of the scrotum. That consent is very, very important, and the examiners trap many candidates there. Okay, so make sure when you are taking consent, you explain the mother, okay, we need you to there is a possibility that the testis might not come down at all, and you might have to do a two-stage procedure. If you're not taking consent, definitely you have to proceed for a delayed setting. Okay, so that's all about
Yep.
the management. And you got trapped in this situation here where you did
Yeah, I
not.
did. I did.
So just write down the points that you're forgetting. And rest,
Mm-hmm.
the last question that was asked is the mother is going to come to you again after the testicular atrophy, and that's how the scenario is going to end. So when there is a testicular atrophy, what are you supposed to do? When there is a testicular atrophy, you are going to counsel the mother that the child, this is a complication which was already explained, and it is seen in up to 10%, can be seen in up to 8 to 10% of the two-stage procedures. What we can do is we can wait till puberty. If there is since this trophy test is not going to cause any problem, if it is causing pain, then we can remove it. Otherwise, we can wait till puberty, and after that, we can consider removing the testis and placing a prosthesis. Okay, here you have to bring the discussion of the prosthesis when it becomes an adult or an adolescent. So at 16 or adolescent age group, you can consider placement of the prosthesis, and that Viva can, if you are really fast and progressing, the Viva will enter into testicular prosthesis from here. Okay. So that's all the feedback
Excellent.
for that undescended testis. And please revise the notes that we have in the class. I think we have, you will find 10 extra points when you revise the notes there.
Okay.
Okay, so here in an undescended testis scenario, I will give you a 5. Okay. So don't mind the marks.
Okay.
5 is a pass. Okay.
Mhm.
Oh, sorry, 6. 5 is not a pass. I guess. Sorry, I forgot. 6.
No worries.
Yeah, it's just a mock exam, so you still have 2 months to improve, and every day we are going to get better. That's what I believe from
Well,
my
I'm writing in January. So I
definitely.
will do this course again with you. After you finish this, I would join back again, be and join.
You have rescheduled your exam?
No, I'm international.
Okay, I got confused. Okay, then we're great.
Yeah.
Okay. So, in this scenario where you were asked about the febrile UTI and all, so the first thing is you mentioned very well. You have to emphasize that you will ensure the child is stable and resuscitation has been initiated with as you said, 10 ml per kg. I don't know whether you said this or not. 10 to 20 ml per kg is actually the ideal dose for resuscitation for bolus with a normal saline, and then you give a maintenance fluid. So that's about the resuscitation, and ensure the child, you have to know whether the child is lethargic. So these are the adjectives for a pediatric patient in an emergency. Unwell child, you will understand when you read unwell child, whether the child is lethargic, whether the child is drowsy, playful. So these are the adjective. Dehydrated. So how do you assess dehydration? Whether the child has temperature. Okay, the respiratory rate of the child, the cardiovascular system assessment by looking at the capillary refill time. Try to bring about all these points to show that you have an idea of how to examine an unwell child. Okay, in an emergency. So that's all we see when we have an unwell child. So make sure you come out with all these adjectives so that you can proceed to resuscitation and quickly come out to the management of this case where the febrile UTI, you will start with after you have done a clinical assessment, you will start the antibiotics, okay, and then you will get when the child is stable and all, you will start with the history as you correctly mentioned about the points in the history. I'm not going into details of that. And examination, you proceeded with I'm not going to details of all these points, you have covered everything. Now regarding this investigations, there was some confusion in that. So again, you were right with the nice guidelines exist for different age groups, less than 6 months, 6 months to 3 years, and more than 3 years, definitely. And we have mnemonics for all this, how to remember this, and this child falls under the second criteria. And the examiner has given you a case of an atypical UTI. So a febrile UTI in an emergency is an atypical UTI, more likely an atypical UTI, and when the examiner tells you, then it becomes more easy. So atypical UTI, we have a mnemonic for this, how to define an atypical UTI. I think you know about this is an abdominal mass. It's a treatment for 48 hours and poor flow, C for increased creatinine, L for increased creatinine and non-E. coli organisms. So infection with a non-E. coli organism, that is I. So all these points have to be brought about. How do you define an atypical UTI? And one of them will be the uh, unwell child. So how do you, so first thing is you get an immediate ultrasound as per the NICE guidelines. Second is you get a TMSA scan at 3 to 6 months, 3 to 4 months. Okay. So you mentioned about the ultrasound, you got an ultrasound. So 3 points you could have added here extra was the parenchyma. Okay, about the ureter, which was not seen in these images, and you could have mentioned about the SFU grading. So that will give you some extra points if you don't forget this. And regarding this, you mentioned about the photopenic area. That's a good point. You could have asked for the function. Okay. Then you got a VCUG scan, and you got a VCUG scan which showed a grade 4 reflux, grade 3 reflux. Okay, you can revise the grading of the viewer. We have mnemonics for them. It's simple. Your diagnosis is established after that, that this is a bilateral vesico-ureteric reflux, and after a DMS scan, you know that there is a cortical scarring as well with a history of febrile UTI. That's all that you have in mind. With this diagnosis, the next examiner is asking you, what's your plan of management? So definitely you will counsel the parents for the medical treatment, and you explained all the points there regarding conservative and the antibiotics. You can be more specific with the name of the antibiotics there. You can add a trimethoprim as well. Okay, and the dose and why you want to trimethoprim, there can be one question there. Then what I have feedback for you is, who are the patients who are likely to require surgical treatment? There are 3 points there. One, you said about the high grade VUR. Second is if the patient has bowel bladder dysfunction, and if a male uncircumcised, they are the more likely to progress to surgical treatment. Is it clear so far?
Yeah.
Okay. So then the examiner is giving you a scenario where he progressed. And again, warning signs. So again, when you're putting a child on a conservative management, the parents have to know about the basic treatment that you said, the bowel bladder function and all that management training about the and circumcision if possible. You can counsel for circumcision. You advise for the medical treatment, antibiotics regimen, and the evidence for that. And then you also explain about the success rate, who are likely to fail and who are likely to progress to surgical treatment. And you also explain about the red flag signs, when to come back. Okay, so you explain their breakthrough UTI. This was the keyword that I was looking for, breakthrough UTI. Okay, apart from that, renal function deterioration, all that you said is all right. Then surgical treatment, HIT technique was the one I was looking for in the endoscopic treatment. Rest of the thing that you said, 80% success rate is all right. That's from the notes. And what about the definitive surgical treatment? You mentioned about the Cohen cross. Okay, there are other ways as also for ureteric reimplantation. It's all right. The standard is Cohen cross at this as per the literature. So you can stick to anyone. That will suffice. Okay, so that's about the second case, and it's a 6 here also. So we have to make it till 8. So it's a long way to go, but mock sessions are definitely going to help you, and practice and practice and practice. Keep practicing. You're going to get better every day. Do you have any questions?
Oh, I think this was excellent. Peds is definitely one of my weaker topics. So being kind of on the spot, yeah, it was very useful. I think these sessions are very useful. So thank you for taking the time to do it.
Thank you. Thank you so much. And okay, so we have another candidate waiting in the queue. Okay.
All right, take care. Have a good day.
Thank you.